Good Gateway morning, everyone, and welcome back to Billing Insights, your favorite podcast for medical billing. If you are new here, my name is Taylor.
And I'm Anita.
And today we're digging into a topic that affects every pain management practice, prior authorizations, how to handle them, who requires them, and how to avoid getting burned. Prior authorizations, or PAs, are basically the insurance company's way of saying we'll pay, but only if you ask first. In pain management, these are not optional. We're talking high-cost procedures like radiofrequency ablations, epidural injections, and spinal cord stimulators.
And don't forget kyphoplasties.
Right.
And let's be real. These are the same procedures that payers love to deny. They're expensive, they get overused by some providers, and that means that you, the office staff, have to go the extra mile. If you don't, you risk denials, appeals, and even worse, the patient has to be told that they're financially responsible for something that they thought was going to be covered.
Right. We recently had a case where a provider skipped the PA for lumbar FRA. The claim denied.
Of course.
That was over $4,000 lost in reimbursement, and it took nearly 3 months to clean up the mess.
So let's talk about how to get prior authorizations approved the right way, especially for pain management. Step 1, know what requires the prior authorization. Every plan has different rules. So some want a prior authorization for every single injection out there. Some only request a prior authorization for the first in a series, and then, they're a little bit more relaxed after that once you prove that something is needed. Traditional Medicare used to not require prior authorizations for anything, and it's kind of started to go a little bit backwards with that. It now requires hospitalization, hospital outpatient prior authorizations, and back braces in some states are also starting to require prior authorizations, but not all states. Now, Medicare Advantage plans like Blue Cross Advantage or United Healthcare Advantage, those are a totally different story. They need prior authorizations for almost everything.
And Medicare Advantage often contracts with third-party vendors. You've probably seen AIM Specialty Health, which includes Anthem and Blue Cross Blue Shield, EviCore, which includes UHC, Aetna, Humana, and NIA Magellan, which has some Medicaid and Medicare Advantage plans. You need to go to their portal, not the main payer, to request the PA.
And here's another little glitch that you might have happen. Sometimes whenever you go to the portal and request for a prior authorization, for example, if you have a 64483 that needs 2 levels, they will tell you that it is approved for the 64483 and the 64484. You submit your claim, and then it gets denied, and you're trying to figure out what's going on. If you submit an appeal into the insurance who denied the claim, it's not going to be paid because they'll just keep telling you that it was denied because of no prior authorization. What you have to do is go back to the portal where you got that, whether it's AIM or a portal directly, and have them resubmit that prior authorization approval back over to the payer. Once the payer then gets that, they will process the claim and actually pay for that second level. It's unfortunate, but we see it happen a lot.
Yeah.
So next step is step number 2, get the right documentation. And here's what's typically required. You need your ICD-10 diagnosis code, such as M54.16 for radiculopathy. You need imaging reports, such as your CT scans, your MRIs, and your X-rays. You need your clinical notes, which show specifically what failed conservative treatments the patient has had. So things like physical therapy, non-steroidal anti-inflammatory medications, and home exercise programs. And it has to be very detailed in the report exactly what it is they've tried and what happened when they tried it. You need your pain scale, physical exam, and your function loss, such as an Oswestry disability scale. And then you need your rationale for why they need that specific procedure and why you think it's going to help. And then especially with AIM and Evercore, sometimes you need more than just the one specific month of note that you're going to send in for any other insurance. Sometimes they'll even go back as far as 6 months to make sure that they can track what has been happening with the patient and what conservative treatments have been tried and failed.
So, step 3 is portal submission. We're going to go ahead and put some links up on the screen now for AIM and Evicor. Some go through Availity or even Cover My Meds. And yes, some still use fax. Just make sure your cover sheet includes patient info, your MPI, and reference numbers if it's a continuation.
And then step 4 is follow up and log every single thing that you do. Once you submit your prior authorization request, don't assume it's moving. Set a 48 to 72 hour follow-up timer, and if it's stuck, if it's still in that pending stage, escalate that to a supervisor. If it's denied, escalate again. Always log your date, your status, and your contact info. And let me just explain one other thing here. Sometimes whenever you call, they will tell you that no prior authorization is required. Don't trust that. We have had providers call in, be told that no prior authorization was required, for example, on a big procedure like a spinal cord stem trial. And we had to go back and fight that because once the claim was submitted, there really was one required. I don't know if that's just the insurance's way of trying to not pay something or what, but it sure seems like it. So what we had and what the provider actually had as proof was the name of the person they spoke to, the reference number of this person, the date and the time that the phone conference took place, and then they can go back and pull those phone records to prove exactly what was said between the provider and the provider rep at the insurance company to prove that we did do our due diligence and try to get the prior authorization, but were turned down.
So step 5 is appeal if denied. Don't just accept the denial. Request a peer-to-peer review. Let the provider speak directly with the medical director. A lot of approvals happen right there.
Yes, they do. And that's typically because the two physicians speaking together have that clinical knowledge that you as the office manager or just the prior authorization staff may not necessarily have. And so it's always helpful if you go all the way through the process and then you still can't get it approved to ask for that peer-to-peer review. So let's get tactical. Pain management offices cannot afford to wing prior authorizations. So build a cheat sheet for your team and for the physicians to know exactly what's required and what you have to do for every procedure that the office typically does. For instance, 64483, that's a transforaminal epidural steroid injection. Is a prior authorization required for that insurance? Do they want left side? Do they want right side? Do they want both? And is it per level or per side on how they do their prior authorizations? For example, a 64635, which is your radiofrequency ablation, does it require a prior authorization? And make sure that the whole team is aware that you have to have 2 failed medial branch blocks in a series prior to doing that radiofrequency, unless they've had one previously in the past year, and you're just doing a repeat. Make sure that they're aware that those add-on codes typically for most insurances are automatically added on to a prior authorization, but not always. So watch for that, whether it's bundled or not. And then, is fluoroscopy included in that procedure? There's a lot of pain management codes where it's included, and there are some where it's not. So if it's not included in that procedure and you have to do it, does the fluoroscopy require a prior authorization as well?
Also, train your front office. Most PA issues happen because the scheduler didn't check benefits or missed a required PA. Build that step into your pre-visit checklist.
And providers, your documentation is key. It can't just say back pain. You have to show failed treatments, imaging results, and why this procedure is the right next step for this specific patient. One sentence won't cut it. It has to be detailed.
And our last tip, Track PA expirations. AIM approvals usually expire in 30 to 90 days. You may only have approval for one injection or a series of 3. If you go beyond that, you're going to need a new auth.
So here's the big takeaway. Prior authorizations obviously are time consuming, but skipping them costs more in the long run. So build your processes, use the right portals, and make sure your team knows the rules.
And if your practice needs help setting up your PA workflows, or you want cheat sheets, staff training, or support with AIM or EviCore, we've got you covered at Gateway Medical Solutions. Also check out our GMS Learning Academy at www.gmslearningacademy.com. We've added new classes. The most recent one was for emergency action plans. We do have 2 new ones in the work. Anita's working on the KPIs, or key performance indicators, so you can track your practice success. And I am currently working on our very, very thorough pediatrics class. Visit us online and level up your practice operations. Also, the website for Gateway Medical Solutions is www.gatewaymedicalsolutions.com. Thank you so much for joining us today. Remember, prior authorizations don't have to be painful, even in pain management. Please remember to like, comment, subscribe, and share, as well as hit that notification bell so you can be notified every time we upload a new video. Thank you so much for your support, and we will see you in the next video. Bye!